Good day. Our topic for this session will be on sources of morbidity and mortality data. At the end of the session, the student shall be able to identify the various sources of morbidity and mortality data used in public health studies and other epidemiologic investigations, accomplish pertinent public documents related to civil registries of vital events, and lastly, determine important community health indices which are of public health significance. So let's talk about the sources of data. We can dichotomize them into two broad categories. You have your primary data and you have your secondary data. When I talk of primary data, these are obtained by the investigator himself or herself firsthand, specifically to aid him or her in answering the different objectives or purposes that his or her study may have. For example, if you gather data from surveys, interviews, if you can perform certain diagnostic laboratory tests, or you conduct physical examination on your study subjects, all these information will determine whether or not your respondent will be able to meet, let's say, the inclusion criterion for your study. And so, whatever information you derive, because you were the ones who personally gathered the information, they are referred to as your primary data. To give more context to this, every single year we bring our freshman batch to our adopted community. For the past several years, we've been doing this in our adopted partner in San Juan City, which is an urban poor area. And this is what you will be doing in a couple of weeks, wherein we will divide you into smaller groups, and each group will be assigned one or two specific families. And your task will be to interview your respondents that will look into the leading causes of illnesses or morbidity cases in their particular locality. So often, based on our timeline, this would often happen every April of the year. Although my photos are not updated, this is as of April 2024. But last year, we also brought our students um, in San Juan City. And whatever information you gather, when you collate all of these data, they will now be used to write your community diagnosis. So that example of getting fresh information is an example of your primary data. In contrast, we also have our secondary data. When I talk of secondary data, these are obtained by other researchers rather, for purposes not necessarily the same as those of your particular study, and are therefore considered previously existing information which might just be helpful in their study. For example, if there is a particular registry and you look for data in such registries, that would be an example of your secondary data. Generally, this type of information has a large bearing with regard to the quality of facts obtained, since the investigator has no control whatsoever on how the data were collected or even the objectives behind the data collection process, as well as the definitions used in classifying individuals into different categories of the variables considered. Sometimes this is also what we do. And when you are promoted to sophomore year, you will also conduct an epidemiologic investigation as a group. And there are students in the past which utilize data relying on previously gathered statistics. Let's say, for example, in our adopted partner in the Barangay Social Hygiene Clinic in Barangay Batis, again in San Juan City, you might look for information relating to HIV/AIDS or sexually transmitted infections. These are information that your social hygiene clinic may typically look into or gather. And so, if you utilize such information, those are all considered secondary data. Now, it is also imperative that from a public health perspective, as doctors, we will be able to recognize medical conditions which might have public health bearing in the sense that it may require us under Philippine laws to report them to certain agencies. There are certain diseases that are required, again, under Philippine legislation, to be notified or reported, in particular to the Department of Health. Now, the DOH also comes up with reports of occurrence of notifiable diseases, providing data regarding the morbidity status of the community. Now, the reporting of these notifiable diseases is generally conducted on a weekly basis and therefore is required for purposes of surveillance and monitoring of important communicable diseases. I think the importance of such registry for your notifiable diseases became very prominent, or it became more uh, more applicable at the height or at the peak of the COVID-19 pandemic. Now, data on notifiable diseases are based on information submitted by health personnel of the various health systems that we have, beginning with the rural health units or the city health offices or the provincial health offices and the municipal health offices. For example, um, currently, I have been visiting certain municipal health offices here in Iloilo City, or if you go to our partner community in the urban poor area of the San Juan City Health Office, you can already get certain information on leading causes of morbidity and or mortality in their locality. Now, under Republic Act 3573, this is referred to as the Law on Reporting of Notifiable Diseases. This law mandates the immediate accounting of any communicable disease of public health interest to the nearest health officer. So even before the COVID-19 pandemic became a reality for all of us, there are already existing laws that will require physicians or healthcare professionals to notify health authorities or local government units that there is a particular, if there is a particular communicable disease that is happening in their area of geographic locality. Now, we also have the PIDS-R. The PIDS-R stands for the Philippine Integrated Disease Surveillance and Response. And what is the main goal of creating the PIDS-R? It is basically to create a unified functional system for early detection, analysis, and timely response to communicable diseases, thereby reducing morbidity and mortality through data-driven decisions, enhanced reporting, and coordinated action across health levels, integrating past systems for better efficiency. Now, you need to understand that the PIDS-R has been in place even before the COVID-19 pandemic because we have been diligently looking into all potentially fatal and epidemic prone conditions. And from a public health perspective, it is imperative that we are able to alert, let's say, the population at large if there is a potential epidemic that may happen in their locality. Now, what are the key goals and objectives of the PIDS-R? Number one, you want to reduce disease burden. You want to significantly lower illness and death from priority communicable diseases by strengthening surveillance and response. When I say morbidity, I'm referring to occurrence of diseases. And when I say mortality, I am referring to death. Now, if you look at, let's say, the health indices, which were recently lectured on you, we look into the incidence rate, the prevalence rate, or case fatality rate. These are important health indices that we can monitor over time to determine whether or not there has been a significant change in the disease burden. For example, in general, when we talk of communicable diseases, we look into its incidence rate. Let me reiterate the previous lecturer's um, key points. The incidence rates refer to the number of new cases within a given population at risk. In contrast, when we talk of your prevalence rate, I am referring to the number of new and old cases in a particular area, in a particular area, looking into the population at risk. Although it's not exclusively prevalence for for prevalence for non-communicable diseases or incidence for non-communicable diseases, they can be both relevant. For example, if I say, what is the incidence rate of type 2 diabetes mellitus in Metro Manila in 2025? When I say what is the incidence of diabetes or type 2 diabetes, I am asking you in 2025, how many were newly diagnosed to be diabetic? In contrast, if I say what is the prevalence of your type 2 diabetes mellitus in 2025, I am asking you how many diabetics were diagnosed in 2025, including those who have already been diabetic even before 2025. So that's the importance of the concept of incidence rate versus prevalence rate. Or when I say what is the incidence rate of HIV in the Philippines in 2025, I'm asking how many newly diagnosed HIV cases were reported in 2025. But if I ask what is the prevalence of HIV, I am referring to as of 2025, we're looking at old and new cases of HIV or people living with HIV as of 2025. Now, the purpose of your PIDs are we are able to monitor over time. We're able to look into the secular trend of certain conditions because if you have a surveillance system, it will give you information on whether or not the burden is decreasing or not. It will also provide timely and accurate information. Remember, if you want to control, let's say, an epidemic, we should be able to know information as accurately as possible so that in the event that there is a need to implement control or preventive measures, you already have the information at hand. And this is where the PIDs R will also come very handy. They provide continuous, reliable data for informed decisions by national programs, the local government units, and other stakeholders. It also allows early outbreak detention, wherein there is a rapid identification of unusual events and emerging threats to enable swift action. Later on, I will give an operational definition of your epidemic and an outbreak. So, an outbreak is synonymous with epidemic, and I will give you the operational definition of the term in a short while. Similarly, the PIDS-R will provide integrated system. Currently, if you look at the available surveillance systems in the Philippines, there are four. The first is the Expanded Program on Immunization or the EPI surveillance system. You have the Notifiable Disease Reporting System or the NDRS. You have the National Epidemic Sentinel Surveillance System or the NESSS. And of course, lastly, the HIV/AIDS Registry. Now, with the birth of the PIDS-R, you are now able to merge fragmented surveillance systems into one coordinated national system. Again, we're talking of primary, secondary data. And so it also allows data driven responses, wherein the PIDS-R will be able to use gathered data for effective interventions, contact tracing, or even follow up on identified cases. And lastly, it strengthens local capacity. It empowers our health workers to detect and respond to epidemics at the community level. That is why, if you look at the previous course that you had last semester, it was disease prevention in the family and the community. It is important that you understand that as doctors, we are not only obligated to look into individual patient care, but we want to emphasize that there is a need to look into higher units of care to include families, schools, and of course, communities or even the workforce. So, looking in all of these information coming from the PIDS-R, these are just some of the key and vital goals and objectives of this particular surveillance system. Now, how does the PIDS-R work? So again, there will be unified reporting. Hospitals and health facilities will notify authorities of priority diseases based on standardized definitions. We look into analysis and monitoring, where data are analyzed to look into trends, secular trends, geographic trends, or verify processes and ensure timely reporting. And lastly, in the context of ARIDs, these are your emerging and re-emerging infectious diseases, which I will be elaborating on in a short while. You also try to look for information that will allow you to administer public health interventions and or actions. So in essence, the PIDS-R aims to transform surveillance from separate components, let's say working in silos, into a single powerful tool for public health action. Now, based on the PIDS-R, they have identified what we refer to as your epidemic prone diseases, your diseases targeted for eradication or elimination, and other diseases or conditions which are of public health importance. Now, I will try to define terms for you to better understand these terminologies. This may have a little bit of change by now, but in essence, these are some of the things that as health authorities or as healthcare providers, we look into all of these. So, for example, if I am a doctor, for example, when I was doing my rotation as a resident physician trainee in toxicology at the Philippine General Hospital, whenever we catch paralytic shellfish poisoning, so these could be your red tide, we have to report them to the PIDS-R. So these are just some of the examples wherein surveillance will be very relevant. If you look at it closely, even dengue is in the condition considered as epidemic prone. Now, truth be told, when I was in medical school, which was not so long ago, we were taught that dengue fever used to be referred as the Philippine hemorrhagic fever. And in medical school, we were once informed that dengue is a seasonal type of condition, wherein it's only evident during the rainy season. Fast forward 25 years later, or 25 to 30 years later, we are looking now at the impact of climate change, wherein instead of having the ulan season, the Philippines encounters about 28 tropical depressions in a single year. That translates to 1 to 3 storms every month. So before, when I was growing up, April, May, June were regarded as the rainy season. But now, if you look at the worst typhoons ever looking at the burden of the typhoons that the Philippines encountered over the years. Ondoy in 2009 happened on a September. Sendong devastated the Mindanao region, if I'm not mistaken, in sometime in December. And we have other typhoons, major typhoons wreaking havoc throughout the Philippine archipelago, January to December. And if you look at the amount of rainfall, it also impacts on dengue. So the epidemiology of dengue also significantly changed because of the impact of climate change. So I want to define the terms epidemic, eradication, or elimination. And I will try to walk you through this, although I know it's a bit challenging because you are only first year medical students, and I do know that you still have no background whatsoever on pathology or medical conditions, but maybe for academic purposes, you just need to identify what the government, or at least the PIDs are, identifies as epidemic prone, what are being targeted for eradication or elimination, or those that are of public health importance. So let's talk about epidemic or outbreak. So when we say epidemic or outbreak, it refers to the disease occurrence among a population that is more than what is expected in a given time and place. Usually, there is an apparent sudden increase. That is why you need to know what is the common incidence rate. Let's say, for example, if Metro Manila has a normal incidence rate of dengue, let's say for example, 500 cases in a month. So for example, 500 cases every January. And then in 2024, in 2023, you had 450. In 2024, 2020, in 2023, you have 400. In 2025, 2024, let's say you had 300. In 2025, you had, let's say, 490. Then all of a sudden, come 2026, it shoots up to 800. Although you know that the usual incidence rate is about 400, and then suddenly an increase in number occurs, then that is what we call your epidemic, or what you call your outbreak. Now, if this outbreak occurs in more than one, if it happens in two or more geographic areas of the World Health Organization, or the WHO divided us into several continents. I'm sorry. So we do have several continents. You do know that. But let's say the WHO divided, let's say, each continent or continents into regions. For example, when you say Australian Asia Pacific region, that could be one WHO region. Now, if, for example, the epidemic happens in more than two to three geographical WHO areas, then that's a global pandemic, just like what happened in COVID-19. Now, other cases would be another terminology, will be something that is endemic. If I say malaria is endemic in Palawan, what do I mean by that? Basically, I will not see cases of malaria in Metro Manila. Why? Because the mosquito vector will tend to thrive in bodies of water which are basically clean and free flowing, which we don't have in in the national capital region. But let's say in Palawan, you do have very clean bodies of water, making it a good medium for your mosquito vector to thrive. So if you say the incidence of malaria in Palawan is, let's say, 50, if I see 50 cases of malaria in Palawan, I would say, oh, that's the norm. That's the usual pattern. But if I see 50 cases in Metro Manila, that's an epidemic because malaria is not endemic in the in the National Capital Region. So when I say Endemic, I am referring to a medical condition present among the population at any single point in time, although in other regions it may not necessarily hold true. So these are three terminologies that you need to do. I will add the word sporadic. Sporadic is like um, something that spontaneously occurs or something that you don't know how it happened, but suddenly it happens even though it is not really expected or it's not the norm. It haphazardly occurred. Now, depending on the situational analysis, some may be considered epidemic, even though you're not referring to exact numbers. What do I mean by that? There was a time that the Philippines was considered poliomyelitis free. When I say it's poliomyelitis free, you do know that there should be zero incidence of poliomyelitis. However, recently, because of the dwindling number of vaccination, sometime in sometime between 2010 to 2013, we lost that status because we were able to identify one wild case of poliomyelitis somewhere, I think, in the Visayan region. So even though it's a single case, it's considered an epidemic. Indonesia, it's not exactly sporadic. It's not exactly, it didn't happen haphazardly, but we are associating it with the lack of or the poor vaccination compliance rate. So even a single case can sometimes be reported as an epidemic, especially if it is potentially life-threatening that could affect the general population. Now, we also try to differentiate elimination and eradication. Are these two synonyms? The answer is a no. When we talk of elimination and eradication, both will have zero incidence, meaning to say, in a geographical area, there are no new cases. The only difference between elimination and eradication, when I say elimination, sorry, sorry, I got distracted. For a while, please. I apologize for that. I got distracted. So, what's the difference between elimination and eradication? Both will yield zero incidence. The main difference, as defined by the Centers for Disease Prevention and Control, for elimination, you need to have deliberate efforts to maintain and sustain that zero incidence. Again, elimination refers to reduction to zero of the incidence of a specified disease in a defined geographical area as a result of deliberate efforts. There are continued interventions being required to maintain and sustain that zero incidence. In contrast, when I say eradication, there is a permanent zero reduction of the worldwide incidence of that disease, and there are no active interventions being implemented to maintain and sustain that zero incidence. For example, when we talk of the variola infection, this is your smallpox. Smallpox has been eradicated from the face of the earth. When I say eradicated, do you see children getting vaccinated against smallpox? The answer is a no. We no longer vaccinate our children against smallpox because of the effective vaccination program that occurred decades ago, perhaps circa 1950s, 60s, that allowed that limited the virus, the variola virus, to be transmitted from one person to the next. That is an example of eradication. In contrast, when I talk of chicken pox, children need to get vaccinated against chicken pox if you don't want children to have your varicella or your chicken pox infection. So the vaccination program allows us to achieve elimination. But herd immunity, concept that you learned last semester, is something that is pivotal if you want to achieve eradication. Now, for those seen by health authorities, the quality of diagnosis can sometimes pose limitations to this data source. Because if you look at the Philippine archipelago, there are facilities, there are your what we refer to as your geographically isolated disadvantaged areas where facilities capable of conducting laboratory tests are usually lacking, and therefore when doctors come up with a medical diagnosis, it is solely based on clinical grounds or clinical manifestations. So this is a clinical diagnosis. For example, if a person consults at the barangay health center presenting with productive cough of at least 2 weeks duration, weight loss, multiple cervical lymphadenopathies with associated blood-tinged sputum or your hemoptysis. These symptoms are highly suggestive of tuberculosis. I can give a clinical diagnosis of presumptive pulmonary tuberculosis, but if I want a definitive diagnosis, health standards will now dictate that you need to subject your patient to a polymerase chain reaction or your MTB RIF expert, gene expert. So there is a difference between your um, bacteriologically confirmed pulmonary tuberculosis versus your clinically diagnosed pulmonary tuberculosis. And this is a sad reality that we see in many parts of the Philippine archipelago, in particular in your GDAS or your geographically isolated and disadvantaged areas. Now, in rural communities where volunteer health workers and midwives are the frontliners, symptom diagnosis is practiced, and only the occurrence of signs and symptoms is reported and not the actual medical diagnosis. In particular, if you are aware with the IMSI or the Integrated Management of Childhood Diseases, this was being advocated by the World Health Organization, in particular in sub-Saharan Africa, wherein there will be doctors. The doctors are only confined, let's say, in the cities, and in the rural areas, nurses or doctors are not present. And so the WHO or the World Health Organization empowered the rural health workers or the volunteer health workers to identify, let's say, with pneumonia, no pneumonia, with measles, no measles, basing it primarily on the occurrence of signs and symptoms. When I say symptom, I am referring to something that is subjective, meaning to say it is a personal complaint of the patient. If I say I'm having abdominal pain, that's a symptom. But if I touch the abdomen of a patient and press it and I elicit tenderness, that's a sign. A sign is an objective parameter documented by the healthcare provider or the doctor. So signs and symptoms comprise subjective and objective findings. So sometimes when you notify, let's say, measles, there is a possibility that in areas where there are no licensed physicians or other licensed healthcare professionals, this is where your symptomatic diagnosis could be acceptable. Let's talk about Republic Act 11332, which is the mandatory reporting of notifiable diseases and health events of Public Health Concern Act of 2020. Looking at the dates, you know that this emanated from the occurrence of the COVID-19 pandemic. When I say disease control, I am referring to the reduction of disease incidence, prevalence, morbidity, and mortality to a locally acceptable level as a result of deliberate efforts and continued intervention measures to maintain such reduction. Then you have your disease response. This refers to the implementation of specific activities to control further spread of infection, outbreaks, or epidemics, and to prevent recurrence. So it includes verification, contact tracing, rapid risk assessment, case measures, treatment of patients, risk communication, conduct of prevention activities, as well as rehabilitation and reintegration. I'm not sure if you remember the contact tracing that we had at the peak of the COVID-19 pandemic, wherein if I get positive RT-PCR for COVID-19, all immediate family members will also be subjective to the testing. And sometimes our movement is limited because of the threat of the COVID-19 pandemic. But be mindful that contact tracing is something that we have been doing even before the COVID-19 pandemic. For example, if I am a person living with HIV and I turn out to be positive for HIV, all my sexual partners from the very beginning would be identified through contact tracing and then alert these individuals that they also need to be tested for HIV because I tested for HIV. Something to that effect when we talk of your contact tracing. Now, disease response will also refer to implementation of specific activities to control further spread of infection outbreaks or epidemics. And again, this could also look into the limitation of movement or restrictions of movements, whether complete or partial, for purposes of controlling the infection. And this is where your quarantine and isolation concerns started. So, if you will recall, at the peak of the COVID-19 pandemic, we did have isolation and quarantine protocols. So, imposition of quarantine controls in specific geographic areas and international domestic travel restrictions could also fall under disease response. Construction of facilities for quarantine of health and emergency frontliners, and the pre-positioning and the distribution of personal protective equipment for healthcare workers. I remember when we started, I was a clinician at the medical city at the start of the COVID-19 pandemic, and we never stopped operations, and we had to wear at the very beginning improvised face masks, improvised we had to wear improvised coveralls because back then it wasn't the norm that people would use, let's say, the face mask. So I remember at the medical city, my first ever face mask was donated by a patient of mine, composed of acetate paper, the transparent plastic. Then there was this what do you call that? Like a foam, and then it had garter. I had to wear to wear a garter. And then I remember my patient gave a quotation, a religious quotation. telling how they are very proud of the medical frontliners. So all of these are all examples of your PPE or your personal protective equipment. So everything started to become a reality for us in the medical frontliners because of the COVID-19 pandemic. That is a response to the epidemic, to the pandemic. So I wanted to differentiate quarantine and isolation. To summarize, both quarantine and isolation refer to restrictive movement of people. When I say you are being quarantined, you are the a person is separated or restricted in terms of movement, but this person is still well, meaning to say this patient has no disease, but there is exposure to a positive case, and that person and you, because of that exposure, gives you the capability to transmit it to another individual. That's why you're being quarantined, for purposes of minimizing chance of you further infecting other people. And knowledge of how long should the quarantine be is dependent on the natural history of the infection. That's why you need to know what is the incubation period. You need to know how long should you see before the frank illness or the overt clinical manifestations become evident. In contrast, when you isolate a person, this person is already sick. You have already been a diagnosed case, and we don't want further spread of your infection to the general public. That is why you are being isolated. When you become clinical clerks or postgraduate interns, you will even know the difference between your clean isolation versus your dirty isolation. But for now, take my word that these are the concepts of your quarantine versus isolation. Now, disease surveillance refers to the ongoing systematic collection, analysis, interpretation, and dissemination of outcome specific data for use in the planning, implementation, and evaluation of public health practice in terms of epidemics, emergencies, and disasters. A disease surveillance system would include the functional capacity for data analysis, as well as the timely dissemination of these data to persons who can undertake effective prevention and control measures. I talked about the ARIDs. These are your emerging and re-emerging infectious diseases. So when I say emerging and re-emerging, often these are medical conditions that have not occurred in humans previously, or they could have occurred in humans but only affected small numbers of people in isolated area. Or these could be medical conditions that have occurred throughout human history but only recently been recognized as a distant disease due to an infectious agent. Or there could be previously undetected or unknown infectious agents, or if these will be secondary to mutations or resistant strains of your causative organism, or once they were considered major health problems in the country, then there was a dramatic decline in prevalence and or incidence, but are now slowly becoming more of a problem again in the population. So I need you to understand what is the operational definition of your ARIDs as per nomenclature of the Department of Health. Now, the notifiable diseases, I also have mentioned to you previously of the PIDS-R classification. But there are also what we call your Category 1, your Category 2 conditions. Category 1 would require immediate notification of the health authorities. Category 2 are medical conditions that are reported by health authorities on a weekly basis. Now, for academic purposes, I guess you will just need to memorize some of these conditions. But bear in mind, let's say when we talk of your category 1, this would include COVID-19, anthrax, your acute flaccid paralysis, which is often associated with poliomyelitis, meningococemia, neonatal tetanus, paralytic shellfish poisoning, or even rabies and HFMD, your hand, foot, mouth disease. Then you have your category 2, which would now include your dengue, your leptospirosis, your malaria, and your pertussis. And then you also have your civil registries of vital events. Civil registration is the continuous, permanent, compulsory recording of the occurrence and characteristics of vital events. When I say vital events, I'm often pertaining to birth and death, as defined and provided through decree or regulation in accordance with the legal requirements of each country. It is done primarily for their value as important records or legal documents, and secondarily for their usefulness as sources of statistics. Now, this is now a bit challenging because I will need to give you a walkthrough on how to properly accomplish a certificate of death and a certificate of live birth, when in fact you have no backgrounds whatsoever yet with disease pathology. So, of course, when we talk a certificate of death, it will entail that you write a diagnosis. Because we're only freshman medical students, that's the big challenge for me. How will I simplify medical conditions for you to better understand the proper way of doing a death certificate? You might say, oh, I will never accomplish a death certificate. You're wrong. When you become clinical clerks, part of your responsibilities is to accomplish a certificate of death. Of course, you will be guided by the consultants and by the resident physician trainees, but it is a skill that you need to learn. So I am teaching you a skill that you will be utilizing when you become clinical clerks or fourth year medical students. So, though challenging, I'll try my best to simplify it to the best of my ability so that you grasp the concept of certification of death. So, a certificate of death is a permanent legal record which contains an individual death information. It provides important information or data on circumstances surrounding the demise of your patient. The information from the death certificates has various uses. It can be utilized for settlement of claims, inheritance, insurance benefit, as well as having a proof of death. The certificate of death is likewise provided to the family members since no body can be buried or cremated without a certificate of death. If you are following if you are following local news, um there was a very controversial issue plaguing our government, wherein a woman supposedly faked her death, and then after years she suddenly appears back, no less in a Senate hearing, and then everyone was surprised saying, akala ba namin patay ka na kasi you presented the certificate of death previously. So these are just some of the stories that you might see how our profession, being doctors, could be linked to the social determinants of health. So, the cause of death is something that must be certified by a licensed doctor, and you need not be a specialist for you to write a certificate of death. As long as you have a PRC license as a physician, you are authorized and you are capable of writing a certificate of death. So, because of this, it is very important that you recognize that whatever you write in the death certificate would have an implication not only for the family members, but even for the way we record our data. Remember, we try to identify the leading causes of mortality and morbidity in the Philippines. So when the Philippine Statistical Authority determines what are the leading killers among Filipinos, they base their data on the certificate of death accomplished by licensed physicians. So, being responsible for the clinical diagnosis of the cause of death, your doctor will play a pivotal role in ascertaining the cause of death. And whatever clinical diagnosis that you make as a doctor, that will be the basis for certifying the cause of death. And when entered into a certificate of death, it establishes the cause of death of that particular individual. So, before you can accomplish the certificate of death, you should be aware of the ICD, or the International Classification of Diseases and for Mortality and Morbidity Statistics, version 11. ICD 11 is also what the PSA, or the Philippine Statistics Authority, will follow in terms of the coding. So for every medical condition, there is an equivalent ICD 11 code. When you accomplish a death certificate or certificate of death, you are also required by law to include the ICD 11 code so that your diagnosis conforms to international nomenclature, international labeling of disease. The information in the certificate of death, which is coded using the ICD 11, is entered into a database that is consolidated rather, by the PSA. Now, the consolidated mortality statistics is the foundation for the country's health policies, plans, and programs. It informs the policymakers and planners on the leading causes of mortality and including its patterns and trends. Thus, it is of utmost importance that the country's mortality data should be of good quality. I tried to see if I can find information on the latest leading causes of death among Filipinos for 2025. However, despite diligent efforts, the PSA only reports the data as of November 2024. But if you're looking closely into these, there is a comparison of what happened in 2023 versus 2024. Because this is the latest information that we do have, there is a possibility there have been changes, but I am of the opinion the changes would just be a difference in the ranking, but more or less it's the same causes of death among Filipinos, with ischemic heart disease, malignant neoplasms, cerebrovascular diseases or stroke, and diabetes mellitus considered to be in the top five. And these are all non communicable. And then you have pneumonia, which is number four, which is the only communicable disease in the top leading causes of mortality. So the number of the causes of death among Filipinos is primarily NCDs. But if you look at the leading causes of morbidity, conditions which may have the highest incidence or prevalence, it is not your NCDs, but it is your communicable diseases. So there's a slight difference in terms of the profile for the leading causes of death or mortality versus the leading causes of morbidity or medical conditions. Okay, so this is where the challenge will come in. So if you see a certificate of death, of course you will need to fill in the information. Where did the death occur, the name of the patient, the date of death, place of death, if you know the religion of the patient, the citizenship, his age, civil status, occupation. These are all necessary. Excuse me. So I think this is self-explanatory for numbers 1 to 13 perhaps, but the challenge will now be for number 19 onwards, especially if you are dealing with children just a few days old. Now, I want you to remember that the road to good quality data starts with the clinical diagnosis of the physician as to the cause of death. This is followed by the precise manner of certifying the cause of death with immediate, antecedent, and underlying causes entered accurately and in correct order. I mentioned to you earlier on that there are times wherein a patient dies, let's say at home, and the death was not attended by a doctor. This is where your verbal autopsy comes in. For deaths that occurred within the Philippines but are not attended by a doctor, the best way of ascertaining the cause of death is via verbal autopsy. And usually, if the death was not witnessed by a doctor, this is the responsibility of the city health officer or the municipal health officer. This is done, the verbal autopsy is conducted by interviewing family members who are knowledgeable as to the probable cause of death. Again, it is the task of the city health officer or the municipal health officer to accomplish the medical certificate the certificate of death and to sign it. In the strictest sense, it is not you are not legally liable to write the death certificate if you did not witness the death or the demise of the patient. However, sometimes out of humanitarian reasons, other doctors are willing to sign out a death certificate even if they did not attend to the patient for various reasons. For example, you have a patient who dies and there is a on the day of the death there is a long weekend because of series of holidays. Because if let's say if a patient dies on on a Friday, Saturday, Sunday, no work for government officials, including the city or municipal health officer. And then, for example, it's November 1, November 2 for Monday and Tuesday. So the next office day for the city health officer will be November 3. So that means for the next 4 consecutive days, there will be no certificate of death. What if, for example, the patient died of highly communicable diseases and you need to cremate or you need to to bury the body immediately? Under Philippine laws, there are provisions for such special situations, which I want you to read on our review notes and manual. So there are special indications or special situations where other licensed physicians or other personalities can accomplish the certificate of death for purposes of burial or for purposes of cremation or what have you. But if you're going to be very academic about it, if I am a city health officer or an MHO, a municipal health officer, it is my task to accomplish the certificate of death for people who died in the absence of a healthcare professional. So, how do we conduct the verbal autopsy? So, the WHO recommends verbal autopsy as a partial solution to the problem of lack of cause of death information in cases where there is no medical attendance. Verbal autopsy is one way of determining the cause of death based on interview with next of kin or other caregivers. This method is undertaken using a standard questionnaire that looks into signs and symptoms, medical history, or circumstances preceding or precipitating the death of the patient. For example, if I ask, Mommy, can you explain bakit paano namatay si tatay? And then they would go, oh, nahulog siya, nabagok ang ulo, tumirik ang mata, duguan, namatay. So more or less you have an idea, oh, there could be blunt force trauma. Or they could say, kita ko sumakit ang dibdib niya, sakit daw ng ganyan, hindi makahinga, namatay. If a patient comes to you presenting with severe chest pain, chances are this is your classical acute myocardial infarction or your heart attack. So you will have an idea already of how the patient died based on the testimonies of family members or relatives who witnessed the death of the patient. Now, verbal autopsy instruments are based on the following assumptions. Each cause of death has a distinct pattern of signs, symptoms, severity, and other characteristics. For example, nakagat ng aso, and then tumirik ang mata, lumabas ang bula sa bibig, naglaway, takot sa tubig, takot sa hangin. These are all classical manifestations of rabies, overt rabies. So that distinct pattern, aerophobia, hydrophobia, um, sensorial changes, aggressive, violent behavior, these are all classical manifestations of your rabies. The signs and symptoms experienced by the disease can be recognized, remembered, and reported by family members, and it is possible to correctly diagnose deaths based on the reported information and to categorize them into groups of causes of death that are used for public health purposes. For example, among us diabetologists, we do know that if you are diagnosed with type 2 diabetes mellitus, if you are to look at the natural history of diabetes, you die either primarily of acute myocardial infarction or your cerebrovascular accident or your brain attack. Heart attack, brain attack, myocardial infarction, stroke. So those are the common exits of your patients. Even diabetics who are on hemodialysis, sometimes they just die either of heart attack or brain attack. Heart attack or stroke. It's almost always the same. Of course, it's a different scenario when you're a type 2 diabetic and then you're run over by a speeding car. Of course, that's different. But otherwise, from a pathophysiologic mechanism, if you talk about diabetes, you do know for a fact that they die mostly because of MI, myocardial infarction, or heart attack versus brain attack or your cerebrovascular accidents. So the main objective of a verbal autopsy is to describe the causes of death at the community level or population level where civil registration death certification systems unfortunately are weak or where most people die at home without having had contact with the health system. When I was still a resident trainee at the Philippine General Hospital, my consultants would give us a rough figure that 9 out of 10 Filipinos die without ever seeing a healthcare professional or a doctor. That information has persisted for decades. And that's still the reality. If you go to talk of, let's say, to the indigenous peoples, the IPs, if you go to the GDAS, the geographically isolated and disadvantaged areas, these are just still some of the these are just the common scenarios that our um countrymen would experience. So when you do the verbal autopsy, there is a physician coded verbal autopsy procedure. The interviewer visits the household where the death occurred to interview the family members, and there is a pre-designed questionnaire that you utilize, and you try to respond all responses in a standardized manner. Then the pattern of responses will be reviewed by the licensed physician to determine the probable cause of death based on the signs and symptoms reported by the respondents. Now, who can certify the death of a person? Of course, if there is a doctor, the doctor can certify it. If there is no medical attendant, again, the certifying officer will be the municipal or the city health officer. In the event that there is no medical attendant in death and the local city health officer is not available for whatever reason, then the mayor or any member of the Sangguniang Bayan or the municipal secretary may issue a certificate of death, however, for purposes of burial or cremation only, not to certify the cause of death. So I want to stress that the death certificate can be issued by the mayor the municipal secretary who are not healthcare professionals, but only for purposes of cause of death, for burial or cremation purposes. But it is still the city health officer or the municipal health officer who would eventually give the final diagnosis for that particular patient. And in the event that this is a medical legal case, then technically it's the medical legal officer who would accomplish the certificate of death. For example, you have a controversial government employee who suddenly allegedly was found at the bottom of the ravine, who's dead, allegedly. So it's medical legal. Whoever conducts the autopsy, that's the medical legal officer, then the medical legal officer, the autopsy ideally should be performed by our clinical pathologists, is the person who would do the certificate of death for medical legal purposes. So why is it important that we have the certificate of death? It's a prima facie evidence of their death for purposes of claims for benefits, pensions, insurance, or tax exemption, evidence of settlement of estate. Let's say if we're talking of a rich person, how do you distribute the wealth of the heirs, the property of among the heirs, remarriage purposes of your surviving spouse, designation of a guardian or a foster parent for minors, to determine health priorities for prevention of death similar to similar case causes in the future. And of course, whatever you put on on the death certificate, the information is also significant for family members so that they would know what caused the death and are aware of the conditions that may occur or could be prevented in other family members. So it's important that you understand why even in times of death, the family plays a role in the entire service delivery network, or at least a key player in the service delivery network. So again, the use of your death statistics would provide indicators of existing infectious diseases and epidemics that might warrant immediate control measures, basis for designing programs to promote public safety and strategies for disease prevention and eradication to serve administrative purposes, in particular in the clearing of files like disease case registers, social security, military service files, electoral rolls, di ba? Ang daming mga parang ghost uh, people na, yung parang ghost voters ba tawag doon? Mga patay na pero nakakaboto pa rin. And of course, our tax registers. Again, for the control of infectious diseases, for the creation of public health programs, even crime eradication, mortality surveillance, health and epidemiologic research, health policy, program planning, mortality differentials are also important. So now let's go to this one. Again, um, I know it's a bit difficult because you have no background knowledge, but let me try to simplify this as as basic as possible. So this is the challenge. How do you write the cause of death? So you need to identify the immediate, the antecedent, and the underlying causes, as well as other significant medical conditions contributing to the death of your patient. So the most recent condition written on the topmost line of the certificate that directly leads to death is what we refer to as the immediate cause of death. Other intervening causes or deaths occurring between the underlying and immediate causes are all called antecedent causes. Now, when we talk of death registries, health authorities would use the immediate cause of death. I'm sorry. I'll skip that first. Now, the underlying cause is the disease or injury which initiated the train of morbid events leading to the demise of the patient or the circumstances of the accident or violence which precipitated the fatal injury. Now, the underlying cause of death is the most important entry in the certificate since mortality statistics is based on the underlying cause of death. Now, on the second part of the medical certificate portion of the certificate of death, this will include other contributory coexisting pre-existing conditions that led to the death but not directly related to the underlying cause of death. So if I go back to my slide, it is your underlying cause of death, which is what epidemiologists or statistical officers would tally as your main cause of death. Now, you also need to include this, the interval between onset and death. Why is this important? Because if you look at the interval, it doesn't have to be very specific. It could be, for example, if you say he's a diabetic, but I don't know how long he's been diabetic, then you put unknown. Or let's say, oh, he's been a diabetic at least for maybe 5 years or so. So approximately 5 years. Why is it important that you put the interval? Because if you put the interval, you would have an idea more or less whether or not there is chronological events from the immediate to the antecedent to the underlying cause. Often the underlying cause would have the longest duration, while your immediate cause would be the shortest. So when you say a few hours before namatay siya because of heart attack. So those are immediate versus let's say he's been hypertensive diabetic for 20 years. So even the duration of the immediate versus the antecedent versus the underlying, it's important. Now, the stated time interval between onset of cause and death would help to check if the causes of death are written in correct sequence, meaning to say the underlying cause, which would have the longest duration, led to the antecedent cause that eventually led to the immediate cause, which would have the shortest interval. If it occurs that after filling out the time interval, the antecedent or the immediate cause is older or would have a longer interval compared to the underlying cause, then you know that it's a faulty death certificate. As a rule, the underlying cause occurred first, and therefore, in terms of the sequence of events, would logically have the longest time interval. You also have to look into infant death. When I say infant, they usually refer to children less than 0 to 7 days. And again, you have to put conditions here that are of medical importance. Let's say you have a baby who was born prematurely. Sometimes babies would have what we call your hyaline membrane disease, wherein because a baby was born prematurely, there is inability for the lungs, for the immature lungs to produce surfactant. You know that surfactant is necessary for the normal gaseous exchange in the lung parenchyma of the lungs. So if you lack surfactant, chances are you may have hyaline membrane disease. And if you do not administer surfactant, your baby can die because of acute respiratory distress syndrome. So if you look at this, the hyaline membrane disease is secondary to the prematurity of the baby. So by just looking at physiology, you do know that a premature baby who lacks surfactant can have hyaline membrane disease that can precipitate acute respiratory distress that can lead to the demise of your baby. But what causes the prematurity? It is possible that the mother developed preeclampsia. When I say preeclampsia, this is elevated blood pressure with associated proteinuria, and it becomes a medical emergency because there could be fetal distress wherein a mother can deliver a baby prematurely. And why did the mother experience preeclampsia? because this is very common among high risk teenage pregnancies. So, as you can see, when you come up with the causes of death, let's say if this were an infant, you're not only looking at the condition of the baby, but you're also looking at the medical factors that precipitated that condition. So, this is, as I've said, it's a challenge for me to talk about physiology, disease pathology, because we're only freshman medical students. But I'm just giving you an idea on how doctors would often accomplish a certificate of death. Now, we don't want ill defined or non specific causes of death. When I say ill defined causes of death under ICD 11, they are basically vague categories and conditions that would just include signs and symptoms and abnormalities documented physically or via laboratory procedures. Now, death assigned to ill defined causes are insufficiently detailed to be of value for public health purposes. Ergo, as a rule, ill defined conditions should never be entered as an underlying cause of death on the certificate of death, unless nothing else is known about the deceased. Now, another problem is that doctors may commit reporting specific organ failure or the mode of dying as the underlying cause. These conditions are still regarded ill defined and therefore should not be reported as the underlying cause of death, since they do not usually occur without a precipitating cause. Therefore, if an organ failure is reported on the death certificate, the underlying condition responsible for the failure should also be reported. What are examples of modes of dying which are considered ill defined? Cardiac arrest, heart failure, syncope o nawalan ng malay tao. You should be able to identify what precipitated, let's say, heart failure. Is the heart failure secondary to ischemia or ischemic heart disease? Is it secondary to congenital heart defects or valvular heart defects? Or is it thyrotoxic heart disease? Or is it cardiomyopathy? So you need to give a plausible reason why the heart failure happened. Or when you talk of shock, is this septic shock? Is this hypovolemic shock? You have to specify, you have to qualify, and then you need to give the cause that led to that. You also have in the ICD 10 what we refer to as your garbage codes. Again, they are referred to as garbage codes because they are ill defined or residual categories of major disease groups that do not provide meaningful information on the underlying disease or injury that precipitated the death. We also want to minimize mechanistic terminal events. These are pathophysiologic or biochemical derangements that are common final pathways that explain how a cause of death exerts its lethal effect. In general, mechanistic terminal events have an almost limitless differential diagnosis and therefore should never be reported in the certificate of death. They are extremely nonspecific and are of little epidemiologic value for purposes of mortality statistics. Example, cardiopulmonary arrest. Even on national TV, you will hear doctors say, oh, the patient died of cardiopulmonary arrest. If you look at it, when you say cardiopulmonary arrest, you stop breathing and your heart stops beating. Can you identify a living person who doesn't breathe and whose heart doesn't beat? It doesn't make sense. So if you say cardiopulmonary arrest, every dead person literally stops breathing and his or her heart will stop beating. So if you put cardiopulmonary arrest, it is ill-defined, non-specific, ergo not highly educated. Let's say pneumonia. If you say, oh, this patient died from let's say pneumocystis jirovecii pneumonia, which is an opportunistic infection among people living with HIV. Or you say this is a community acquired pneumonia on top of hospital acquired pneumonia on top of ventilator acquired pneumonia. So HAP cap on top of HAP on top of VAP. So medyo marami. Or when you say sepsis, is this sepsis secondary to a urinary tract infection? Is this urosepsis? So you need to specify the underlying cause if you want to be very specific. Now, another issue is you need to identify certificate of death for maternal conditions. So for every woman age 15 to 49, regardless of whether they're pregnant or not, you need to accomplish the maternal condition. And the fact that the woman died during pregnancy or within 42 days upon the termination of pregnancy, this should also be indicated in the maternal death review. Now, a maternal death refers to the demise of a woman while pregnant or within 40 days of termination of pregnancy, regardless of the duration or the site of pregnancy, let's say ectopic man yan or uterine pregnancy, or any cause related to or aggravated by the pregnancy or its management, but not from accidental or incidental causes. Among Filipinas, the top causes of maternal death would be still their postpartum bleeding, complications of unsafe abortion, hypertensive disorders of pregnancy, which would include your preeclampsia, or if there will be seizures, it's your eclampsia, then your postpartum infections and obstructed labor. I want to look into number two, unsafe abortion practices. Abortion is not legal in the Philippines, but it contributes to the burden of maternal death. Many women who want to terminate unwanted pregnancy would need to resort to unhygienic, unsafe abortive practices simply because it is illegal in the Philippines to commit even therapeutic abortion. So it's something that is very controversial. It will require bioethics, but I'm giving you the heads up that if you look at WHO guidelines, WHO, not guidelines rather, but standpoint, the WHO opines that therapeutic abortion should be a decision to be made by women, not by society. So I want you to you will further discuss this in bioethics, but I just want to park this idea that abortion, in my opinion, is not absolutely evil or absolutely wrong. For certain individuals, therapeutic abortion may be indicated. And again, it's up for discussion, it's up for debate, but I'm just parking the idea for now. Other important things to you remember when you're doing you're accomplishing the certificate of death. You If there will be uncertainties in the entries, we will use terminologies presumptive, probable, or sometimes we use undetermined natural cause. So when you are requested to tick something or don't you use an X mark rather than a check, then check for correct spelling including the names of the disease. Maraming mga Pilipino, Rehey, Bohoy, Johanna with an H. So make sure that you properly spell the names of the disease properly. Or the Dela Cruz. Is the Dela one word or is it Dela? I'm sorry, Dela two words or Dela one word? Or the use of the enye. So you need to be very particular about the spelling. We are not to make erasures or alterations. We do not use abbreviations or medical symbols, and we use permanent black ink, not blue ink, not vermilion, not pink. It has to be black pen. Now you want to record one etiology per line in the cause of death. The line A, often the immediate cause of death, must have one entry. Now sometimes if the condition on line A resulted from another condition, put it in another condition on line B, and so on until the full sequence is reported. Hindi naman kailangan palaging merong line A, line B, line C, no? Kuminsan, it could be very straightforward. So it's really a matter of the level of confidence of the doctor on how to properly accomplish a certificate of death. And always enter the underlying cause of the lowest used line in part one. Now, what about deaths involving external injuries? So the approach to writing causes of death involving external injuries is to report the external cause or event as the underlying cause and to identify the bodily trauma caused by the external event and report it as antecedent cause. And lastly, report the fatal derangement resulting from the bodily trauma as the immediate cause. The external event refers to an outside agent or force, usually physical or chemical in nature, that causes trauma, an injury, or damage to bodily tissues or its functions. The trauma in turn may result in anatomic or functional fatal derangement that often leads to the patient's demise. So, for example, if you want an immediate cause of death, let's say you have a patient who dies from a vehicular accident. Sometimes, if, for example, if I am an MHO and I didn't see, let's say this is a John Doe who dies, let's say, in the emergency room, but I know this patient was run over, let's say, by a speeding truck. I could most probably put here there could be hypovolemic shock because of extensive bleeding secondary to multiple fractures because of the blunt force trauma precipitated by the motor vehicular accident. So that is something that I can write in the immediate, antecedent, and the underlying causes of death. Now, in the same manner, um, if the certifier is not certain on the manner of death, the physician can simply stipulate undetermined intent. Now, I also want you to take note of 19D and 20. So, if the manner of death is something, let's say, a suicide, or if it happened, let's say, on the street or in the factory, let's say, may sumabog on the spot, namatay. So, yan yung, remember just recently, two kids died, well, one kid died, while one is severely deformed from a blast of a firecracker injury blast in Tondo. So, yeah, yung mga ganyan, manner of death, di ba? Accident, it happened on the street. If these are all external causes, especially if you feel that there could be um, possible medical legal implications, then an autopsy ought to be performed. So if it's an infectious disease, the certifier has to report the manifestation of the body site, for example, pneumonia, or if the causative agent is unknown, you can write unknown. You just have to put the source of infection. For example, my earlier infection, in earlier example, it could be your pneumocystis jirovecii pneumonia among an opportunistic infection among PLHIV, or it could be your community-acquired pneumonia na patungan ng hospital-acquired pneumonia na nagdagan pa ng ventilator-assisted pneumonia nung inintubate yung pasyente. So you have to put all of these. And the underlying disease that may have suppressed the patient's immunity that made him susceptible to the infection that led to the demise should also be reported. If it's secondary to cancer, you have to specify the site of the neoplasm because public health prevention strategies would also differ depending on the type of cancer. The primary site must be stated, and if ever there is a secondary growth, it should also be stated. Let's say, for example, prostate cancer with metastatic bone cancer. The primary is your prostate, then the metastasis is to the bones. So you have to put the primary site. Now, the certificate of death should always state the primary site, and sometimes if there will if you, the site is unknown, we just simply say underlying cause Primary site is the underlying cause of death. Now, what about fetuses? Fetal death refers to the demise prior to the complete expulsion of a product of conception, irrespective of the period of pregnancy. The death is indicated by the fact that after such separation, the fetus does not breathe nor show any other evidence of life, such as the beating of the heart, or if you look at the umbilical cord, it should have two arteries in one vein. If there will be no pulsation from the umbilical arteries, then it could be suggestive that there is no life. Or if the patient is limp and no definitive movements of the voluntary muscles. Now, usually, for all fetal deaths aged 20 weeks and above, as calculated from the start of the last menstrual period to the date of delivery, you also need to accomplish the certificate of fetal death. Now, in the certificate of the fetal death, similar to what was mentioned, let's say, for example, the main cause of the death is the fetus died because of abruptio placenta, secondary to preterm labor. Uh, and the reason for the preterm labor of the mother is, let's say, she is a drug addict, cocaine intoxication. Sometimes by just putting abruptio placenta, you need not give any other conditions of the fetus. That's already understandable. Now, here, another thing that could be difficult is the length of pregnancy. If you can identify the number of completed weeks, it would be best. So in obstetrics, you will learn about this. There is also a difference between your preterm versus your early, full, late, and post-term babies. So yung number of completed weeks, it's important that you document that. You ask for the last menstrual period, which is the onset of the last menstrual cycle, not the first day when the menses stopped. So the first day of the menses is what we call the LMP, or the last menstrual period. Now, for the fetal death, the single most important will be the main disease or condition. And then sometimes if you can put the main maternal disease or condition, and that would be also relevant. Now, there is also what we call your peri-procedural death, referring to demise that is known or suspected to have resulted in a whole or in part from the diagnostic, therapeutic, anesthetic, or operative procedures. You might say that if a patient dies on the operating table, it's automatically negligence. No, it's not. So let's say there could be what we refer as your misadventure or your iatrogenic or errors in accidents, but sometimes there could be procedural deaths that do not actually involve negligence, mistake, or culpabilities. What are these? So, for example, a peri-procedural death could be referred to as natural or accidental. When I say the peri-procedural death is natural, the death was imminent and that it would have occurred anyway, even the procedure was not done to the patient. For example, the patient is already, um, let's say, a patient, let's say, for example, I'm not an obstetrician guy, but let's say there is disseminated intravascular coagulopathy. There's a bleeding with the patient, and decided to open the patient because you want to see if there is any bleeding blood vessel. You opened up the patient, hoping to control any form of bleeding. But even if you do not form the bleeding, even if you do not perform the surgery, if the patient has DIC and the patient will eventually bleed to death anyway, then that's natural. Accidental happens when the death occurred simply because the procedure happened, and the demise would not have transpired if the procedure was not performed. So that's the difference between your natural and your accidental death. Now, again, just to reiterate, when we talk of medical legal examinations, those death secondary to violence or crime. Under Philippine laws, it's medical legal. We have to report them to the PNP, the Philippine National Police, and or the National Bureau of Investigation, who will conduct the autopsy. So examples of violence of crime and violence or crime would include stab wounds, gunshot wounds, suicide, so on and so forth for your perusal and for your academic records. Yung mga Operation Tokhang, yan, mga gunshot wounds, yung mga death by execution ng mga dati, no? And in the previous administration. Another concept is dead on arrival. Ano bang ibig sabihin ng dead on arrival? ER deaths refer to patient mortality occurring in the ER, including patients who were revived but initially resuscitative measures who were revived by initial resuscitative measures but eventually died there regardless of time or stay in the ER. Now, in such cases, if you're going to be very strict about it, other people say, ay, namatay siya pero sa ER, nabuhay pa siya ng 3 hours. Pero bakit yung doktor sinabi dead on arrival? The reason why we say it's dead on arrival, for example, a patient comes to the ER, you give initial first aid, you're able to stabilize the patient, then you transfer the patient from the ER to the room. Let's say you're very quick about it. You were able to transfer the room to the patient to a private room in 15 minutes, in from 15 hours upon entry to the emergency room. And then on the 16th hour, in the private room of the patient suddenly dies. That is still dead on arrival. Any death that occurs in less than 24 hours is considered less than 24 hours upon admission in the facility is considered dead on arrival. So hindi kailangang literal that you need to be dead, no breathing, no heart rate for you to be labeled dead on arrival. It's possible that you were stabilized at the ER, transferred to your room of choice, but in less than 24 hours you die. That is still dead on arrival. Under Philippine laws, any doctor who has a dead on arrival patient can refuse to make a death certificate. And it is the city health officer, or if this is something, let's say, controversial, hindi mo alam kung pinatay, binaril ba yan, tinukhang ba yan, if you suspect foul play, then you can defer the issuance of the death certificate, let the medical legal officer accomplish it, or the city or municipal health officer. That's an important time for you to understand dead on arrival. So, if we're talking of death, we also talk of live birth. Now, just to give you an idea, so if you look at the certificate of live birth, there are information that you can easily accomplish, but you need to understand certain concepts relating to the certificate of live birth. I'm not an obstetrician gynecologist, but let me walk you through the basic concepts of gravidity and parity. Gravidity refers to a pregnant state, whether or not you completed the pregnancy. As long as you became pregnant, that's your gravidity. And the parity refers to the number of times you delivered the pregnancy, regardless of the period of beyond the period of viability. So it's possible I've been pregnant 3 times, but let's say I'm suffering from antiphospholipid antibody syndrome, wherein my body recognizes the growing fetus as foreign, so I develop antibodies to eliminate the foreign body. That's her APAS. And women with APAS have challenging pregnancies. So you can be pregnant 3 times, but you never reach term for you to deliver. So you could be G3, gravidity 3, but parity 0, G3, P0. Women have your OB code. Both gravidity and preparity refer to pregnancy and not babies. So, for example, if I am a first time mom and my first pregnancy resulted in twins, I am still considered G1, gravidity 1, parity 1. I hope that's clear. Now, if you turn this page, you need to understand that there is a legal concept that you also have to understand as early as now. I am not a lawyer, and you will encounter legal medicine and medical jurisprudence in third year, but allow me to give you an overview of how things will happen. So we look into the issues of paternity. If you turn the page of your certificate of live birth, you have here the affidavit of acknowledgement of the father, and to use the surname of the father. And if you look at the family code of the Philippines and you look at Republic Act 9255, there are certain issues that you need to understand first. So if you look at the affidavit, so the father, the biological father of an illegitimate child, can write this affidavit acknowledging the child, but there are certain issues that you need to understand. What is a legitimate versus an illegitimate versus legitimated? What are legitimate versus legitimated children? Any child who is born out of the proper marriage is a legitimate child. A mother and a father who deliver a baby, they have legitimate children. Now, what are illegitimate children? Um, if you look at Philippine laws, these are children who who were born not because of the normal marriage. There are, let's say, you have living in arrangements. We call these are common law marriages. Nag-live in lang. Or it's a child born out of incestuous marriage, bigamous or adulterous relationship. Ibig sabihin ng bigamy and adultery, when the parents deliver the baby, the either parent would not have the legal ability na magpakasal. For example, girl number one and boy number one got married. They separated, but their marriage is still valid. Then boy number two comes to the picture. And boy number two and girl number one started to have a sexual relationship and they have a baby. But because the baby was born to girl number one, who is still married to boy number one, but the father is boy number two, that child is illegitimate because at the time the baby was conceived, there was no ability for the mother to marry boy number two. So when you say illegitimate, there is no legal basis that will allow for that child to be legitimated. Legitimated children are illegitimate children, but they're born to parents, single parents, and the single parents eventually marry. So, legitimate and legitimated children in terms of succession, in terms of property, pareho ang legal rights nila. But an illegitimate child will only have 50% in terms of succession of property kasi illegitimate siya. So may konting legal issues. I'm not a lawyer, but I just want you to have an idea. There is a difference among legitimate children versus legitimated children versus illegitimate children. Now, for the illegitimate children, prior to August 3, 1988, if the father acknowledges them in the likod, then that child can carry the surname of the father. Again, for illegitimate children born prior to August 3, 1988, based on our family code, that illegitimate child can use the surname of the father for purposes of using the name of the father and for succession issues. However, for children born after August 3, even if the father acknowledges the child, the illegitimate child can still not use the surname of the father. The father of an illegitimate child who wishes to have his name indicated in item 13 of the certificate of live birth shall execute an affidavit of admission of paternity in lieu of the affidavit of acknowledgement. Now, the purpose of the affidavit of admission of paternity is for the support and succession only, and it does not entitle the illegitimate child to use the surname of the father. Under the family code, an illegitimate child born after August 3, 1988 shall use the surname of his mother for legal purposes. So that is under Philippine laws. So be careful also when you write your certificate of live birth. Alamin nyo, kasal ba talaga yung mga magulang? Kasi under Philippine laws, baka mamaya, kunwari lang ha, masampahan kayo ng falsification of public documents. Kunwari lang, simply because you did not know that this is an illegitimate child and you accomplished a public document such as the certificate of live birth. Fetal death in utero. There is a difference between your abortus and your fetus. I believe the Philippines follows the US National Center for Health Statistics, wherein we say an abortus is any conception born 20 weeks or less, or in the event that the woman was able to um successfully pass out the baby. If the baby is less than 500 grams, then that is an abortus. Why is it important that you know an abortus? Because an OBGYN code of a female will not only identify gravidity and parity, but you also indicate how many children were born full term, preterm, how many were abortions, whether spontaneous or induced, and how many are currently living. So let's go back to our example a while ago of the twins. If I were a preemie gravida who delivered twin babies and I delivered term, meaning to say 37 weeks and above, then I would be G1P1 because the pregnancy is full term. So um whether it's early term or full term or late term, we call them full term. Pero pag less than 37 weeks, 36 and below, they are considered preterm. And then the third digit is the number of abortions. Kaya diyan nyo importanteng malaman the difference between an abortus and a fetus. And then the last is the number of living children. So if I delivered twin babies, my OB code will be G1P1, gravida 1, para 1, 1 full term, 0 preterm, 0 abortion, but I have 2 living children. So I hope you understand the OB codes. And again, when you go to obstetrics and gynecology, you will have more of these as exercise in the future. So, what have we discussed for today? We've looked into the various sources of morbidity and mortality data, differentiating your primary from your secondary data. All of these can be utilized in public health studies and epidemiologic investigations. Some pertinent public documents related to civil registries of vital events would include the certificate of death, certificate of fetal death, the certificate of live birth. And important community health indices, which are public health concern, um, would include cause-specific incidence and prevalence rates. That's why you need to know the leading causes of morbidity and mortality for purposes of creating government health programs, prioritizing budget. All of these emanate from the reported causes of conditions based on morbidity and mortality data relying on incidence and prevalence rates. So my reference for today's lecture will be as follows. If you want to do supplemental reading, please do so. And I would highly encourage that you also take note of everything that is included in your review notes and manuals. I believe these are all important for purposes of understanding the subject matter even better. So with that, thank you and have a pleasant day, everyone.